Welcome to the deep dive. We're here to basically rip the most critical facts right out of those dense academic chapters for you. Today, it's a high-speed tour through a really foundational chapter on antihypertensive drugs. If you're studying for exams, getting ready for clinicals, well, this is your shortcut. Our mission, simple. We want to rapidly pull out those, essential knowledge nuggets, the mechanisms, the big side effects you cannot miss, and the clinical pearls for managing hypertension. Stuff you need in practice.
Yeah, and it's crucial we start with what we're actually treating here, hypertension. It's defined as persistent systemic arterial pressure over 14E90. And it really is the silent killer. Think about it. About 1 in 5 Canadian adults has it. And often you feel absolutely nothing until disaster strikes: stroke, heart failure, kidney failure, serious stuff.
Okay, so let's ground this. The single most important equation, I think, for this whole field. Blood pressure equals cardiac output times systemic vascular resistance. BP equals COX SVR.
Exactly. Spot on. Every single drug class we're about to talk about hits one of those targets. Either CO, how hard and fast the heart's pumping, or SVR, the resistance in the vessels, or, sometimes the fluid volume that impacts both. If you get which variable a drug affects, you basically understand its mechanism and, importantly, its risks.
Right. Okay, before the fixes, let's quickly touch on the types. Most cases, like 90–95%, are primary or essential hypertension, meaning, well, we don't really know the exact cause.
And that small leftover bit, 5–10%, that's secondary hypertension. That means the high BP is actually a symptom of another problem. Could be kidney disease, maybe preeclampsia, thyroid issues, things like that. But for that huge majority with essential hypertension, we lean heavily on the Canadian Hypertension Education Program guidelines. You'll hear them called CHEP.
And for students listening, knowing those specific CHP target goals is absolutely vital, isn't it?
Oh, absolutely. And they're very individualized. Generally, the aim is less than 190 millimeter Hg using those standard non-automated cuffs. But if the clinic uses automated office blood pressure, AOBP, the goal actually gets tighter. Less than 135 AA5.
Why tighter with AOBP?
Well, it usually cancels out that white coat effect, where just being in the clinic makes your pressure jump. AOBP takes multiple readings quietly, so it's often a bit lower, a bit more representative. And here's where it gets really specific for high-risk folks. If someone has diabetes or chronic kidney disease alongside their hypertension, that goal drops even further. We're talking less than 130/80.
Wow. Those numbers really matter for protecting organs long term. Okay, but before we even think about drugs, we have to talk lifestyle, right? Non-pharmacological management.
Foundation. Absolutely the foundation. We're talking things like the DA-ISHOSH diet. Really watching sodium, cutting it to less than 2,000 milligrams a day is huge, and regular aerobic exercise, like 30–60 minutes, 4–7 times a week. Limiting alcohol, too.
All crucial. But if those aren't enough...
Then we bring in the meds. There are 7 main pharmacological categories. Generally speaking, the guidelines often point to thiazide diuretics as the first choice, unless there's a compelling reason, like another condition, to pick something else.
Okay, let's start with the system that gives us that instant control over SVR and CO, the sympathetic nervous system. We'll look at the adrenergic drugs.
Right. These meds basically interfere with the body's fight-or-flight response. We can start centrally, inside the brain, with the alpha-2 agonists. Think clonidine, mesaldopa. They work by stimulating these inhibitory alpha-2 receptors in the brain. This kind of tells the brain to turn down the sympathetic volume coming out to the body. Less sympathetic signal means lower BP and also less renin release from the kidneys.
Okay, less fight-or-flight drive. What's the big takeaway, the danger zone?
The critical thing, the absolute must-know safety point for clonidine especially, is rebound hypertension. If you stop it suddenly, the BP can shoot up dangerously high. It's a huge patient education point. Never stop abruptly.
Got it. That rebound risk really underscores why sticking to the plan is so important. Okay, let's move from the brain out to the periphery. Alpha-1 blockers, like doxazosin.
Yep. So these block the alpha-1 receptors that are actually on the blood vessels.
In blocking those.
Causes dilation. Arteries and veins relax, which directly drops that systemic vascular resistance, the SVR. Oh, and a kind of neat side benefit. They also relax smooth muscle around the bladder neck, so they're actually quite useful for guys with benign prostate hyperplasia, BPH.
Ah, okay. Dual purpose sometimes. But the main side effect here, the big nursing flag.
Orthostatic hypotension. Big time. And something called first dose syncope fainting after the very first dose. It means you absolutely must teach patients to change positions slowly. Go from lying to sitting, wait a bit, then sitting to standing, slowly.
Crucial safety advice. Okay, so we hit vessels, SVR. Let's shift to the heart, CO, with beta blockers. Metoprolol, propranolol, common ones.
Right. These primarily block beta-1 receptors, which are mostly on the heart. Blocking them reduces heart rate and the force of contraction. Less pump, less cardiac output. They also have a bonus effect of reducing renin secretion, which helps lower BP too. But, and this is key, you have to know the difference between cardioselective ones, which mostly hit beta-1.
Like metoprolol.
Exactly. And the non-selective ones, like propranolol, which block both beta-1 and beta-2 receptors.
And why does blocking beta-2 matter so much?
Because beta-2 receptors are also in the lungs. Blocking them can cause the airways to constrict bronchoconstriction. So if your patient has asthma or COPD, a non-selective beta blocker is a definite no-go. It's contraindicated.
That makes sense. Now, something I found really interesting in the materials was this point about ethnocultural implications.
Right.
It said beta blockers and ACE inhibitors might not work as well on their own for patients of Black heritage.
That's a really vital clinical consideration, yes. Research shows patients of Black, African, or Caribbean descent often respond less effectively to monotherapy with beta blockers or ACE inhibitors compared to, say, CCBs or diuretics. It likely relates to differences in the renin-angiotensin system activity and salt sensitivity in some populations. Understanding this helps clinicians make a better first choice and avoids ineffective treatment trials. It's about tailored therapy.
Definitely important for personalized medicine.
Okay, let's pivot from the nervous system. Let's talk about the body's big volume and pressure regulator, the RAAS system, the renin-angiotensin-aldosterone system.
Yes, the RAAS. It's designed to aggressively jack up blood pressure, especially when the kidneys sense pressure might be too low. Think of it like this cascade. Renin kicks it off, leading eventually to angiotensin II. Angiotensin II is a super potent vasoconstrictor. It clamps down blood vessels hard. Plus, it tells the adrenal glands to release aldosterone.
And aldosterone makes you hold on to salt and water, right?
Right.
Increasing volume.
Precisely. So the whole system hits both SVR and CO. It's powerful. So naturally, we have drugs to block it. First up, ACE inhibitors. Captopril, enalapril, the prils. How do they work?
They inhibit the enzyme Angiotensin-Converting Enzyme, or ACE, that's needed to make angiotensin II. So less angiotensin II means less vasoconstriction, less aldosterone, lower BP. They also have a side effect, or rather another mechanism. They stop the breakdown of bradykinin, which is a natural vasodilator.
Okay, and these ACE inhibitors have some major benefits beyond just BP lowering, don't they?
Huge benefits. They are cardioprotective. They actually help prevent the heart muscle from changing shape, remodeling after a heart attack. And crucially, they are highly nephroprotective, meaning kidney protective. They reduce the pressure inside the kidney's filters, the glomeruli. This makes them the absolute go-to drugs for hypertensive patients who also have diabetes. Protects the kidneys like nothing else in that group.
Massive benefits.
Yeah.
They come with some infamous side effects, the ones everyone remembers for exams.
Oh, yes. Number one, that characteristic dry, hacking, non-productive cough, it's thought to be caused by that bradykinin buildup we mentioned, can be really annoying for patients.
Number two.
Angioedema. It's rare, maybe less than 1%, but it can be fatal. It's swelling, often around the face, lips, tongue, and potentially the larynx, closing off the airway. It's a medical emergency.
Okay, cough, angioedema, and number three.
Risk of hyperkalemia, hypotassium. Because less aldosterone means the body doesn't get rid of potassium as effectively, so you need to monitor potassium levels.
Got it. Cough, angioedema, hyperkalemia, key ACE side effects. Now, there was a detail about prodrugs.
Right, a quick pharma point. Most ACE inhibitors are prodrugs. They're inactive when you take them and have to be metabolized by the liver to become active. However, captopril and lisinopril are the exceptions. They are not prodrugs, they're active as is. So if you have a patient with significant liver problems, choosing captopril or lisinopril makes sense because you don't need the liver to activate them. Good clinical nuance.
Makes sense. So if that ACE cough is just too much for someone and it affects a fair few people, maybe up to 10%.
Then we often switch to the next class in the RAAS pathway, the Angiotensin II Receptor Blockers, or ARBs. Think losartan, valsartan, the sartans.
How are they different?
They tackle the problem one step later. Instead of stopping the production of angiotensin II, they block the specific receptors, the AT1 receptors, where angiotensin II would normally bind to do its work. So you still make angiotensin II, but it can't effectively cause vasoconstriction or aldosterone release because its parking spot is blocked.
And the key clinical difference? especially regarding side effects.
They don't affect bradykinin levels in the same way ACE inhibitors do. So that troublesome cough is generally absent with ARBs. That's their main advantage over ACE inhibitors, though they share the risk of hyperkalemia and, much more rarely, angioedema.
Okay, good alternative if the cough is an issue. And there's a newer class targeting RAAS even earlier.
Yep, the direct renin inhibitors. Aliskiren is the main one. This drug binds directly to renin itself, the enzyme that starts the entire cascade, blocks it right at the source. Less common, but another tool in the box.
All right, moving away from RAS now. Let's circle back to drugs that directly relax blood vessels, vasodilators. We touched on calcium channel blockers, CCBs like amlodipine. You said they're often first line.
Yes, very common, very effective. They work by blocking calcium channels in the smooth muscle of blood vessels. Less calcium entering the muscle cell means the muscle relaxes, leading to vasodilation and lower SVR.
Okay. Then there are the direct vasodilators like hydralazine. How do they fit in?
They also act directly on the vascular smooth muscle to cause relaxation, but through different mechanisms than CCBs and not involving the adrenergic receptors we talked about earlier. They're generally used less often for chronic management, maybe more as add-on therapy.
But within this direct vasodilator group, there's one specific drug we absolutely have to flag, the high alert drug.
Sodium nitroprusside, absolutely. This is not your everyday BP med. This is for the ICU, for true hypertensive emergencies. We're talking terrifyingly high pressures, like over 1 inch and 120 Cs, often with signs of organ damage. Its action is incredibly fast, potent vasodilation, and its half-life is super short, maybe 10 minutes.
Which means?
It requires constant minute-by-minute adjustment via IV infusion, usually with an arterial line for real-time BP monitoring. If the pressure drops too low, you stop the infusion and the effect wears off almost immediately. It's very powerful, but needs intense management.
And the high alert risk associated with it. Why is it flagged so heavily?
The risk of cyanide toxicity. Seriously.
Yeah.
Especially with high doses, prolonged use, or in patients who have kidney problems and can't clear the byproduct thiocyanine effectively. It requires meticulous monitoring of the infusion rate and duration, and sometimes lab tests to prevent a lethal buildup.
Wow. Okay. Definitely want to respect. Let's bring this all back to the bedside. The nursing role here seems absolutely critical with all these potent drugs. Assessment is key.
Paramount. Absolutely paramount. You need thorough baseline assessments, medical history, allergies, current meds. And then ongoing monitoring is vital. We're talking regular BP checks, obviously, but also checking BP supine and standing to catch that orthostatic hypotension, especially with alpha blockers or volume depletion, apical pulse rate and rhythm, especially with beta blockers or CCBs, and keeping an eye on lab values. Serum potassium is crucial with RAAS drugs and diuretics, creatinine to monitor kidney function, especially if initiating an ACE inhibitor or ARB. A jump in creatinine over 30% from baseline needs reporting could signal trouble.
Makes sense. Now let's talk about maybe the biggest hurdle to patients actually staying on these life-saving meds long term. The source material really highlighted sexual dysfunction.
It's a tough one. It's listed as a potential adverse effect for almost all classes of antihypertensive to some degree, and sadly, it's probably the most common reason patients just stop taking their pills, often without telling their prescriber.
Which is dangerous, especially with the rebound hypertension risk we mentioned for some drugs.
Exactly. So open communication is key. We have to create a space where patients feel comfortable bringing this up. And patient education needs to be constant.
Like what key points?
Well, reinforcing safety. Change position slowly. That dizziness risk is real. Emphasizing adherence. This therapy is usually lifelong. You can't just stop when you feel better and never stop abruptly, especially those alpha-2 agonists or beta blockers. That rebound can be deadly. And encouraging self-monitoring, keeping a simple journal of BP readings, maybe daily weights. Report sudden weight gain like 1 kilo, about 2 pounds in 24 hours, or 2.3 kilos, 5 pounds in a week. That could mean fluid retention, maybe worsening heart failure.
Good practical tips. What about major drug interactions to watch out for?
2 big ones to remember. First, NSAIDs, things like ibuprofen, naproxen, they can actually counteract the effects of ACE inhibitors, making them less effective at lowering BP. Patients often take these over the counter, so you need to ask. Second, combining any RAS blocker, so ACE inhibitors or ARBs with potassium supplements or potassium-sparing diuretics, dramatically increases that risk of hyperkalemia. Very important interaction to catch.
Okay, good flags. So, wrapping this up for you listening, what's the big picture? We've really hit 7 major ways to tackle high blood pressure, all boiling down to reducing cardiac output or systemic vascular resistance. From the fast-acting adrenergic system drugs, remembering that rebound risk with clonidine, to the RAS blockers with their amazing kidney and heart protection, but also those key side effects, cough, angioedema, potassium.
And understanding why we might choose one over another, like avoiding the cough with ARBs, or the special considerations for different patient groups, or the high alert status of nitroprusside. It's a lot, but it fits together. And if we bring it back to that real-world challenge adherence and that major issue of sexual dysfunction, it makes you think, doesn't it? Given how serious hypertension is and the risks of stopping meds like rebound hypertension, what specific communication strategies do you, as a future nurse or clinician, need to develop? How can you make sure your patient feels truly heard and supported about a really sensitive side effect while also keeping them safe and ensuring they stick with treatment long term? That's where the art meets the science.
A really vital question to ponder as you take this knowledge into your practice. Thank you so much for joining us for this deep dive. We really hope breaking down this chapter helps you feel more confident. Thank you for being a part of our little last-minute lecture family. Check out the resource links for more study materials and blog summaries.